All right. Good afternoon. Like Betsy said, I am Kristen Topping, and we're going to talk a little bit about exercise training post-stroke. So to start off, I don't have any disclaimers to discuss. And our objectives today are going to be to summarize the importance of intensity of exercise for patients post-stroke as it relates to improving their walking speed and distance. Participants are going to be able to give case examples of post-stroke participants, and we'll be able to develop 1-hour treatment sessions with appropriate heart rate recommendations. So you should be able to apply this to your practice. Participants will be able to identify contraindications to high-intensity exercise. Participants will be able to distinguish inappropriate interventions within traditional physical therapy from newer recommendations. So one of the reasons why I decided to talk about this is the APTA came out with some new clinical practice guidelines to improve locomotor function following chronic stroke, incomplete spinal cord injury, and brain injury. These came out in January 2020, but I also attended a conference, and we'll talk about this a little bit later, that Betsy and I actually attended the same conference that discussed some of the same concepts. So we'll review one of those studies. So the goal of the clinical practice guidelines was to determine specific treatment interventions to improve walking speed and time distance in ambulatory individuals greater than 6 months following onset of a CNS diagnosis, like the ones I mentioned: incomplete spinal cord, brain injury, and chronic stroke. We're going to focus on chronic stroke, but these can be applied to all of those areas as well. So it's set up in 8 action statements. The first action statement, I need it in presentation mode. Sorry. Okay. Having some technical difficulties here. All right, we'll just wing through this here again. So the stroke facts, I didn't go through yet, but I just got this off the CDC website. Basically, there's 40 strokes every second in the United States. About 795,000 people in the United States have had a stroke, 610,000 of those being their first or new strokes. Nearly 1 of 4 individuals have already had a previous stroke. And stroke is a leading cause of serious long-term disability. It reduces mobility. More than half of the stroke survivors over the age of 65. So this is why these CPG guidelines and these recommendations are pretty important, because there's large populations of people dealing with these functional mobility limitations. Sorry, everyone. Okay, so the first action statement is moderate to high intensity walking training following acute onset central nervous system injury. So I kind of put my thumbs up and thumbs down of what we think. Is this going to be a recommendation, or is this not going to be recommended? And so everybody has already seen that. So this is a huge thumbs up. This is one of the major recommendations that are coming out of the CPG, is that the moderate to high intensity walking training is what you're going to find to give you increased walking speed and walking distance. So effects of high-intensity walking exercise are consistent across studies. There's a lot of studies that have been out. We're going to talk about the views today. There's LEAPS that kind of started all of this, and then there's been a whole bunch of variability walking task and intensity studies that have come out in between from like 2005 to about now. They're still working on it. So there are references in the back of my presentation that kind of reflect all of those if you want to take a look at them more in depth. But most of the studies that were included in the CPG guidelines talk about treadmill or overground walking training 3 times a week for 30 to 50-minute sessions. The max heart rate that they're getting their patients to were between 60 and 85% of their predicted age norm, and they're training for 3 to 6 months. So a lot of intensive training, probably a lot more than what we do in the clinic as therapists right now. And with all of these studies, everybody found improved outcomes in 6-minute walk tests, so endurance and distance walked, and 10-minute walk tests their walking speed. Some considerations, and these might be some barriers that we might have in the clinic for patients, if they have uncontrolled cardiovascular or metabolic diseases, obviously if they have musculoskeletal diseases or injury, that might limit us from doing this intense walking. For severe neurologic deficits, you might want to consider getting some cardio testing done before. We want to make sure we're consulting physicians that they can tolerate and handle this intense training. And then if we need to, we might be able to consider modifying treatments to seated for like cycling, or if we feel like patients are unsafe balance-wise, using harnesses in the clinic. The advantages of this kind of training is it's inexpensive and it can be implemented in pretty much almost any setting. So intensity matters. This is the motto now for locomotor training from the Academy of Neurologic Physical Therapy. You see this logo everywhere. It's really cute. It's one of my favorite ones, but it's intensity matters. There you go. Okay, so action statement 2, virtual reality walking training following acute onset CNS injury. Thumbs up, thumbs down. Actually, it gets a huge thumbs up. This is another highly recommended treatment mode for increasing distance and speed walking with this patient subset. One of the reasons why we think this is working really well is because patients get to train in environments that aren't otherwise available in our treatment settings. So they can do outside walking in a park, they can do some grocery shopping. It's basically the settings are endless, I should say. So this may increase patient participation. They might be more motivated to walk. They might make a fun game out of it. But right now, there's not a particular protocol. So there's augmented reality, there's immersive virtual reality. A lot of the studies used one or the other. But it's definitely an awesome area to explore and to continue to look in, because they did get good results. Okay, so strength training following acute onset CNS injury. Thumbs up or thumbs down? It's kind of like It's kind of like in the middle. There is some research that shows that if you are performing strength training at higher intensities, so 70% of 1 RM, that you'll be able to maybe elicit that high intensive training and see some progress in walking speed and distance, but across the board, findings were inconsistent. So that's why it's kind of like maybe yes, maybe no, and more research is needed. Cycling interventions following acute onset central nervous system, again, iffy. Not a major yes, not a major no. Some considerations. Current evidence not as strong as mid to high intensity walking training. There is potential benefit if it is performed at the higher intensities. It can be performed in most settings, and most studies need to compare cycling with other task-specific protocols. So most of the studies were just about cycling and didn't compare it to other conventional treatments or high intensity walking. So more research is needed, and I think that's why it's kind of in the mid-range there. Circuit and combined training following acute onset. Same thing as cycling, kind of in the mid-range there, maybe. So that's kind of the same issue. The studies that they found, again, were not comparing it to task-specific studies. It was just all about circuit training. And again, if they were performing them at higher intensities and it included balance, strengthening, walking, patients did show to get better, but findings were still inconsistent across the board. Balance training alone to improve walking speed and walking distance, same thing. Results are sort of inconclusive for particularly the same reasons. Body weight support system, this is a big one. So this is everybody kind of wants to get their patients, unweighted, so they take weight off that limb so they're able to walk more. But what they found is this doesn't really help them increase their speed or their distance. High intensity walking training without body weight support is actually more effective in getting your patient better, faster, and moving quicker than the body weight support system. And the robotic assisted walking training. So here's two models. This is actually interesting because when we were at our conference, we saw some examples of these robotic devices, and there were patients walking around in them and being really happy that they could move their limb. And as clinicians, when you're dealing with a hemiparetic stroke that's pretty dense, you look to these to help you because that's a lot taxing on us as clinicians to help patients walk and move this way. And so we look for these devices to help us out in a way that takes the load off of us. However, not recommended in the CPG guideline, in the guidelines, only because the patients are relying on an external source to move their body part for them. But what we're finding is if you're getting the volitional movement, you're making your neurons and your muscles work, that's what's going to build the strength. That's what's going to get that reciprocal pattern into those patients. That's what's going to help them walk faster and further, rather than having something else do that for them. So it's not to say that these devices, body weight support system and robotic assisted, are not helping anybody in a clinic. Yes, there is a population, but for the the ambulatory patient population, 6 months post CNS acute injury, this is not an ideal strategy or treatment plan for them. Those are the 8 action statements, and intensity matters. So the other half of this, so that was the clinical practice guidelines. A lot of research was included in there. If anybody's interested, I recommend that you go in and read it and check out all the literature. Like I said, back in November 2019, so last November, I threw my daughter her first birthday party, and then, as any loving mother does, I packed my bags and left her and went to Chicago with Betsy McCormick, and we attended the ACRM conference. This conference is the American Congress of Rehabilitation Medicine. That's what ACRM stands for. It's an interdisciplinary conference, which is really neat experience because you have clinicians from all different disciplines in all different areas of the country. Speech therapy, physical therapy, occupational therapy, physicians, physiatrists, neurologists, general practitioners, clinicians who treat in the hospital, out of the hospital, and gave a variety of different talks on different topics. This is their general program. They have different areas that different branches that you can go down, so neurodegenerative diseases, just regular research, what's going on, brain injury, musculoskeletal. So if you're interested in any of this or you have any questions about the setup of the conference, you can ask Betsy or myself, but it was definitely a good experience and something that we would probably attend again. So one of the talks that we went to there was for this particular paper. George Hornby was there, Dr. Hornby. He practices outside of Chicago, and he is one of the leaders, and he was part of the CPG group that put out those guidelines, and he has a lot of research in this area. And we sat through a lecture on this study, and we really internalized it and tried to figure out, how can we put this into our practice patterns and how can we do this in our clinic. So I'll go a little bit through the study. Oops, sorry. So the study design, I think I am too far. Okay, the study design basically included single unilateral supratentorial strokes, and their acuity was 1 to 6 months. So remember, the CPG is saying anybody 6 months and out, and now they're starting to do the research for more acute stroke patients. What are we doing with that population? Included in this, these participants need to be able to walk 10 meters over ground with min to mod physical assistance, so by a therapist, or without physical assistance, but at less than 0.9 meters per second, and that's their self-selective speed. And they could use assistive devices or bracing as needed. They excluded anyone that had a previous central or peripheral nervous system or orthopedic injury that may limit independent ambulation, uncontrolled cardiorespiratory disease, and inability to follow 3 steps. Their study was performed over a course of 2 years, and patients were recruited from their surrounding inpatient and outpatient clinics. Their interventions for both groups, so they had a treatment group and a control group because it was a randomized controlled trial. I don't think I mentioned that in the beginning. But everybody received 40 training sessions that were about 1 hour each, and they were over 4 to 5 sessions per week over 10 weeks. Both groups wore validated accelerometers around their paretic ankles, and they wore it during their training and outside of training, so they were constantly tracking how many steps they were taking per day. And then days with less than 10 steps, they took out and excluded them and just figured that maybe the participants weren't wearing their accelerometers that day. So the session goals for the training group. So we're talking about the training group now. The goal was to maximize their stepping activity at high intensities up to 40 minutes for the whole session. Pre-gait activities and gait kinematics were not a focus. So clinicians were not focused on any of the pre-gait that we once thought was needed. But they were allowed to use their assisted devices, and they could use their bracing as needed. The training group, training at higher cardiovascular intensities was focused on a variability of stepping tasks that were divided into 10-minute segments. So there were 4 tasks that they divided and gave 10 minutes each. So the first thing that they would focus on was step-dependent treadmill training. It was just forward treadmill training, trying to get the patient to increase their heart rate, increase the amount of steps that they were taking. And again, they were trying to raise heart rates up to 70 to 80% of the max heart rate, or greater than 14 on the RPE scale. So here's how they calculated their age predicted norm, or for their heart rate max or their heart rate reserve. I'm not going to go through a whole bunch of that. We all know those equations. And then they used pulse oximetry to obtain their heart rate during their sessions. All right, so training group, the second. So they had forward treadmill walking. Now they're going to do skill-dependent treadmill training that included perturbation. So they wanted to challenge postural stability, propulsion, and limb swing. So they were going to walk in multiple directions, over inclines, use weighted vest, or use ankle weight, something to increase that intensity. The perturbations were applied 2 or 5 different tasks at a time randomly within that 10 minutes. And difficulty was reduced if the patients were not successful 3 to 5 consecutive stepping attempts. We'll go through a little bit more of that and what that means later on. Then after they did their skill-dependent treadmill training, they did overground training, which means they got to walk off the treadmill around the clinic. They focused on high speeds, variable tasks as desired based off of what the patient needed, and with use of course, a gait belt if for safety, or overhead mobile or rail suspension system for safety, but not body weight support. So kind of like our solo steps that we have in our clinics. And then stair climbing. So over static or rotating stairs, they were looking for that reciprocal stepping pattern over and over again, progressing to higher speeds or higher intensities and decreasing use of handrails. That was the training group. Now the control group had continued with their traditional physical therapy. So controls still went to therapy, like any outpatient clinic, maybe 2 to 3 times a week. That was set at the discretion of the therapist that was treating them. And the control therapy session was supplemented then by experimental therapists, the research therapists, to achieve 40 sessions over 2 weeks. So they did their general physical therapy, and then they would come in and work, come and work with the research therapist during the week to make sure that they got in as many sessions as the training sessions, because that's not typical, or 4 times a week for a stroke patient is not typically what we see at this point in time. So they wanted to make sure that everybody, control group, training group, had the same amount of sessions. Okay. The intensity of all the activities was targeted at 30 to 40% because they had done literature reviews of what the current treatments were, and they had done medical record reviews of what stroke treatment looks like, this is where most clinicians are training their patients at now, 30 to 40% of the heart rate reserve. So that's why they chose that. And therapists could focus on kinematic tasks because that was a lot of what they were seeing in their medical record reviews, and at particularly lower intensities. And some of the other areas that they focused on during these control supplement sessions were active exercise, passive stretching, transfers, specific balance activities, gait activities, and stair climbing are all included with the controls. So the outcomes were performed by blind raters. Measurements were taken at baseline, midline, post, and then with a 2-week follow-up post. Self-selected gait speed and fast selective speed over short distances was measured using pressure-sensitive walkway. 6-minute walk test at patients' preferred self-selective speed were also measured. And if participants, like in the beginning, needed assistance with walking, they documented it as 0 meters per second. So they were saying that, they needed assistance and they couldn't ambulate on their own. So here are the results. If you look at the top, self-selected velocity and 6-minute walk test had significant improvements based from the experimental group versus the control group. So, which means that the patients that were just focusing on high intensity walking, going through those 4 10-minute activities, significantly hit the significant threshold actually in getting better. The second 2 graphs on the bottom, BORG balance scale and sit, 5 times sit to stand was also measured. And they didn't notice any significant change, but they didn't also notice any decrease. It was kind of the same. So even though the high intensity walking group didn't go through specific static, dynamic, balance exercise, they didn't go through transfer training, they still had just as much improvement as the conventional group. So it's kind of interesting to think about if you're just walking your patients, everybody's gonna say, well, what about their transfers and what about their balance? But it's looking like that's still going to improve over time too. So we may not need to be so specific in those areas. So just something to kind of consider. And they're doing more research on that, but we kind of thought that was really interesting. And then this is, sorry, can I go to my notes for this one? Again. Yeah, so this is significant. Oh, this is steps per session, sorry. An average peak heart rate with self-selected speed and 6-minute walk test. Same thing, there were significant improvements for the self-selected speeds. There were obviously more steps, and the same thing with the 6-minute walk test. All right, so we're going to go back to our intensity matters. So just another kind of refresher, just to remember that how hard you're working your patients, how often you're working your patients, and repetition are really important in getting them better. So I put these up here. This is from the Neuro, it's neuropt.org. It's the Academy of Neurological Physical Therapy. So of course we're talking about heart rate monitoring, and it's continuous heart rate monitoring throughout the whole session. So it's not kind of like do a task and put a thing on your finger. They want it continuous. So they really recommend the polar chest straps. But so here the brand is all on your left side, and then the device number, and then you can go ahead and click the link. And like I said, it's neuropt.org, where you can find a lot of these resources. It's really helpful. And so these are some of the monitors that the research was using in the CPGs, and some of the monitoring that was happening in the VIEWS research as well. So some things to consider. Obviously, we know as clinicians that there are specific drugs and medications that can affect your heart rate response, and here's just some to list a few. Beta blockers and calcium channel blockers are ones that we see, that I typically see most often. When you have that, you're going to use your BORG scale then, because obviously the heart rate response to exercise may not be what you want it to be, or it may not be working out to what you expect it to be, because those beta blockers are lowering the heart rate. So you want to make sure that the patients are familiar with the BORG scale. They are accurately rating themselves, and the goal is to stay 14 or higher on the BORG scale, and that's how you know you're getting your intense training. So that's where you kind of want to educate your patients to be working. So it's hard, very hard, extremely hard, and they're doing their max exertion. And then some contraindications for exercise or physical activity. If their resting heart rate is greater than 100 beats per minute or less than 50 beats per minute, if they've got their resting systolic blood pressure is greater than 200 or less than 90, their resting diastolic blood pressure is greater than 110, and their oxygen saturation is less than 90%. Of course, you want to have some conversations with patients and check into if they're taking their blood pressure medications, or maybe, a phone call needs to happen to the doctor. You want to look for other signs of, uncontrolled sweating, cyanosis. If there's any swelling that's abnormal for them, any recent weight gain, of course, we're going to contact the doctor and not work with them that day. Indications to terminate your exercise. So if you are exercising, and this is another concern, I think another barrier for therapists, they're really worried about exercising these patients at really high intensities. So just make sure that you're monitoring all the time their heart rate. If there's a sudden drop of greater than 15 beats per minute, you might want to take a rest and slow it down. If the systolic blood pressure gets higher than 200 or decreases to less than 90, or if there's a drop of 10, a drop greater than 10, kind of just sit down, take a rest, reevaluate, and same thing with diastolic if it gets greater than 110. And then, of course, oxygen saturation less than 90%. Those aren't all like new things, but just something to kind of have in the back of your minds. All right, so some clinical considerations. So intensity matters. I don't know if I've mentioned that before, but let's consider that intensity matters. And motor learning principles, and I kind of reviewed this before, but repetition, intensity, and task specific. This is all what we need to facilitate neuroplasticity. We know that stroke patients can, make adaptations to their brain. They can relearn things, and so this is how we're going to do it. We're going to do it lots of repetitions. So a lot of the articles before from the practice guidelines had 30 to 50 sessions of physical therapy. The intensity was they were working hard, 70 to 85% of their max heart rate, or 14 or greater on the BORG scale. And their task specificity was walking, just focusing on variable walking over and over again at high intensities is really what we want to be looking at, or considering, I should say. So here's the slide again that I said we would come back to. This is from the Views article, and this is the skill-dependent treadmill training. So this is kind of where it gets like a little bit fun, and we talked about that we don't necessarily need to do pre-gait, we don't need to do gait kinematics, but they do focus on successful forward stepping. And so what does that mean? Because of course, like everybody wants their patients to walk normally. They don't want them to have any gait dysfunction. So a successful forward step in the study was considered no foot drag, no limb collapse in the stance phase, and they have frontal sagittal plane stability. So you could add verbal cues, you could add manual cues, you could add bracing as appropriate. And then once this was achieved, then you could add demands on it. So once they had a successful forward step, that's when they would start adding their perturbations of ankle weights, and I'll get there too, it's coming. So increasing task-specific demands. There are 4 subcomponents of successful biomechanic walking that your target impairment during your walking. So your limb swing, your weight bearing in the stance phase, like I said, propulsion, how much exertion you're putting into that movement, and then your sagittal frontal plane stability. So in these areas, if a patient was unsuccessful for more than 3 to 5 attempts, the difficulty was reduced. Again, if they weren't performing the way that you wanted to, we wouldn't challenge them more, and that's kind of a similar way that we've been treating. We'd want to make sure that they were successful until we started adding demand onto them. And then the limb swing. So you can assist the patient to advance their limb until they are able to self-advance. So that's the goal, obviously, right, is to get patients to move on their own. And then once they can self-advance their limb, they don't need you to physically help them or your verbal cues, increase the demand. Use a posterior directed elastic band for resistance, use the ankle weights, start using obstacles, start challenging them a little bit more. Weight bearing and stance. Second one, provide support to that limb until they're independently achieved. So again, manual assisting or bracing. They use both things and both are appropriate. And then if you want to increase your demand, reduce the use of their external support, reduce the assisted device, and start using some weighted vests. Propulsion, provide manual or elastic assistance at the pelvis. So they're pushing through something. Their effort is to push forward and propulse themselves. Use that volitional force that we're trying to gain. So to do this, you're going to increase elastic resistance at the hips, reduce their upper extremity assistance. You can have them walk at faster speeds, and you can start having them walk on inclines to help with that propulsion. And then the sagittal frontal plane stability. Initially, you can assist with handrails, assist device, mechanical or elastic bands, kind of get that trunk control, but then you're going to start increasing demands once they can do this on their own, reduce their upper extremity assistance, backward sidestepping, stepping around obstacles, compliant narrow uneven surfaces, dual tasking. So now you're really kind of perturbing them in all sort of different planes of motion that we need to walk dynamically and have dynamic balance. So this is just, I'm recommending that every clinic get one of these. So everybody put it in your POs for capital budget. No, I'm just kidding. But this is something that we saw at the conference, and it was really cool. And it was something that I think would be really cool to implement with these strategies that we're talking about. So this is a Hookoma. It's a C-mill treadmill. It's got like a virtual reality component, so you can watch, you can walk through different environments and different settings. But if you look on the ground of the floor of the treadmill and the tread of the treadmill, they've got different obstacles. So some obstacles you have to step over, some obstacles you have to step on top, some obstacles you have to avoid, some you have to shift to the right, some you have to shift to the left. You can control how far the obstacles are, you can control how wide they are, and then it also has a support harness on it as well. It's got handrails just in case, and you can take those away as needed, but I just think that this would probably be pretty cool to have for this kind of training. Okay. One last time, intensity matters, just in case we didn't get there yet. So just to review, again, the Academy of Neurologic Physical Therapy, www.neuropt.org, puts on a really good, gives you like a lot of good cheat sheets and a lot of good guidelines, and so this is right from there. And if you look, we're all worried about doing our calculations and doing math and worrying about equations, but they, on the left side of my screen, they give you ages and they give you target heart rates at 65, 75, 85% of those max heart rates. So you can kind of let this be your guide. You can take a look at it. If you have somebody in between the 25 and 30 range, you want to calculate it out yourself, go for it. But that's kind of nice to just have in the clinic at your desk, kind of just handy. And then on the right, the clinical practice guidelines to improve function is the little cheat sheet there of the green, yellow, and red lights. And it's kind of what I demonstrated when we were going through the clinical practice guidelines before. Clinicians should, you get the green light, okay, perform walking training at moderate to high aerobic intensities up to 85% of their heart rate max. And walking training with virtual reality was also shown as a green to go. Where you want to maybe consider, you're in the yellow light zone, strength training greater than 70% of 1 repetition max. Again, getting that intensity in. Circuit training, cycling, or incumbent stepping up to 85% of heart rate max. And balance training with virtual reality. I don't think I mentioned that before. So balance training on its own didn't show a whole lot of improvements for walking, but the balance training with virtual reality actually showed more promise. So virtual reality, just general walking, and just balance training, might be a good consideration with locomotion training. And then your red lights, okay, things you should not be doing with these patient populations following chronic stroke, incomplete spinal cord, or brain injury. You should not just be focusing on static and dynamic balance activities that include pre-gait. You should not be using body weight support treadmill training with an emphasis on kinematics, and robot-assisted gait training also doesn't seem to have any benefit. So, I don't know if you can read it. It says intensity. Use some restraint. You could poke your eye out. So, yes, we're talking about intensity. We went through all of our contraindications for exercise. These are recommendations. You know, obviously every patient is different. As clinicians, we're trained individuals to work and exercise with these patients. So, of course, if these recommendations are not working for your particular patient, that's okay. But I think it's really important for us to try to go for it and make adjustments as needed. So here are some resources that weren't necessarily included in this presentation, but might be something that you want to take a look at. And then I included the website for the Neuro PT section. And then here are my references. Any questions? Anybody have? Patrick McCormick is typing a question. While Patrick types, I'll also just kind of put this out here too. So the Neurologic PT section is having their first annual conference in Minneapolis this year in August, and next year, 2021, sorry. And to piggyback that is the second vestibular rehab. So everybody kind of always asks us about vestibular courses or where are good vestibular courses to go. So I think it's really great that they're starting to put the vestibular conference in it. So it might be something that you guys want to consider. But of course, feel free to ask us questions at any time. Okay, Patrick. What were the specific diagnoses for the contraindications? Because everyone with chronic CVA had a cardiovascular event. You know, that's a good question, Patrick. I'm not really sure what the specific diagnoses are. I can look back through the study, but I don't actually think that they mentioned. I know they talked about like congestive heart failure, with uncontrolled like edema, but that would be the only one that comes to the top of my head, but I can take a look back for you. Yeah, and that was from the Neuro PT website. Any other questions? All right, well, thank you everybody for coming, and if you need to contact me, you know where to find me. Okay, thanks. Thanks everybody, and Steve should be sending out an email soon so you can find out the details on how to get credit on my e-learning. Thank you.